Good afternoon, everyone. Thank you for joining us today for the month of August webinar here at the Phia Group. Conflicts abound, providers and facilities fight back. It's not Star Wars, but it's pretty close, folks. Everyone, I'm happy to be here in Canton, beautiful Canton, Massachusetts on this beautiful August day here in Boston. I'm not stuck at home like a lot of other people on the call with me today. It's just great to be here. What do we know about this month, folks? This important webinar is needed because what we're noticing, as you all know, claim volumes are down across the industry. There are less claims being billed by facilities, by doctors, by providers, by specialists, and they want their revenue. So we're going to talk about all of this today. It's really important to do so. Just know, folks, in addition to my normal, excited, energetic self, my assistant walked into my office a couple minutes ago, gave me a big bag of just candy, like I needed. So, I don't know what's going to happen this hour, but I've already had a couple Snickers bars, a couple M&Ms. I've had some Sour Patch Kids already. So I'm thinking it's Halloween time, but I don't actually think we'll have a Halloween this year. I'm not really sure. But very similar to our next slide, Matt, if you don't mind. Trying to stay ahead of the coronavirus, obviously COVID-19. Feel free to email us with any and all of your COVID questions. We've answered thousands of these already over the course of the year, as you all know. So very similar to what they're doing here in Massachusetts with schools, where there is either a virtual only school session starting in September or some type of hybrid approach. What we're going to do is we're going to have Brady, Jen, and Ron just randomly show up at random people's offices next month, so we can do a hybrid webinar as well. What do you think of that idea, Ron? That makes sense?
Yeah, Adam. I like the creativity. The sugar is obviously driving some creativity.
I'm just saying, we could do a hybrid approach to the webinars. Like I could show up at GPA's offices and just start talking there. I think, with the mask on, of course. All right, Matt, next slide, if you don't mind. What are we going to talk about today, folks? And by the way, thank you to it's like thousands of people on August. Don't you have anything better to do than to be on this webinar today, folks? Hang up, go outside, do something, have some fun. Anyways, updates, PGC FAQs. A lot of letters there. Political update with you-know-who, industry hot topics, and then provider relations in the COVID-19 era. Is it era or era, Ron?
I think it depends on where you're from, but I'm going to go with whichever way you want to pronounce it there, Adam. I think it's era.
Okay, I'll do that. Feel free to chat with us if you want to tell us what you think. Next, please follow us on LinkedIn. Oh, sorry, I messed up. You're right. Matt, you got me, buddy. Today's speakers, obviously you have that good-looking guy on the left with that beautiful pink tie. That's me. As always, say hello to Ron Peck. Say hello, Ron.
Hello, Ron.
I'm going to skip the next guy for a second. I want to make sure we talk about the amazing, the wonderful, the probably most popular person at Phia. Say hello to Jennifer M. McCormick. Say hello, Jen.
Hello.
There she goes again. Won't say Jen. And as always, he used to be just a once-in-a-while guy, but now he's with us every single time. Say hello to our director of La Cara, our Telemundo expert, Brady Bizzarro. Say hello, Brady.
Hello, Brady.
All right, now we have one addition to the team. He has recently been promoted to Senior Vice President of Provider Relations here at the Phia Group. Prior to that, he was an intern. I want to make sure everyone says hello to the first time speaking on a webinar. Say hello to Jason Davis. Say hello, Jason.
Hi, everyone.
What is that? Ron? Brady? What's going on here? Did you hear him?
I did. He sounds like, he's just hanging out. Saw you at the mall. Hey, how's it going, Adam?
It's supposed to be, hello, Jason. That's what he's supposed to say. But anyways, he's not following through. But that's all right. Matt, let's go to the next slide. Please feel to follow us on LinkedIn. We got thousands and thousands of followers, as you all know. Go to LinkedIn and search for the Phia Group, and you'll find us there to find everything possible about this webinar and all the other stuff that's happening in the health insurance industry. As well, this webinar will be available directly after we finish on our website. You can download all the slides and have all the audio as well. In addition, please be sure to download our podcasts. Make sure you listen in on Apple Podcasts or on Google Podcasts. They're hilarious. They're great. They're fun to do when you're just running out for a jog or out for a walk, whatever it might be. And as we do every single month, I want to say thank you for listening to, what a great name, Ward Humphreys. Sounds very serious, very presidential. I mean, he is. He's a vice president. Wow. Senior Vice President of the National Healthcare Practice of Risk Strategies. Ward, thank you for listening. He told us that in addition to his 3 kids, by the way, Ward, I have 4. I have an 85-pound old English sheepdog named Nigel, who likes to sleep on his back and is scared to death of thunder and lightning. I have a 10-pound French bulldog who is literally crazy. I mean, I don't know. We definitely got her on the discount rack. But now, Ward, I almost called you Nigel. Ward, thank you so much for listening. Matt will be sending you a huge care package with a bunch of stuff in it. I do not want to tell our listeners, guys, what we're sending. Last month, I apparently said a T-shirt, and about 10 people texted me saying I never got a T-shirt when I had my shout out. So apparently, maybe we're out of T-shirts. Then I don't know, Ward. I don't know what we're gonna send you, but it's gonna be a bunch of Phia stuff. Next slide, please. So PACE certification, folks. More and more of you are signing up. 75% of all PACE certified TPAs are reporting the tools provided have already increased their PACE adoption rates, meaning you have highly educated people. What does PACE talk about? It's all free. Chapter 1 is literally the ins and outs of self-funding. Any new employee or organization should be, I would say, required, just like they are here, to understand at least Chapter 1. Chapter 2 takes a deeper dive into the laws that apply to self-funded plans. And Chapter 3 talks about the fiduciary transfer of PACE and how it's utilized. Please contact Michael Vaz at mvaz@phiagroup.com or just reach out to any of us here on the panel. Next slide, Matt. Subrogation value reports. We're very excited about this. Almost all of our clients have received this already after the first quarter. We've got some great feedback from them. We have new balance billing reports, unwrapped value reports. Our PACE reports are all coming out by the end of the third quarter. We're truly excited about it. If you have any questions or want to discuss any of this, please feel free to reach out to me. Next slide, Matt. In addition, as you all know, we have a new client success team here at Phia. So we have a group of people led by Rebecca McGuire-Dye, Mike Vaz, and Krista, who literally are here for anything you need. We have never had this previously at Phia. This is pure, innovative outreach, proactive outreach to all of our clients and prospects, just to talk about, what we're not doing right and how we can actually fix it. So it's very important for us to do that as well. Next slide, if you don't mind. Phia International. Yes, folks, we are now global. Not like the pandemic, but we are international. We now have Jason Davis, our Senior VP of Provider Relations, and Nick Fitzsimmons, who is our Senior Director of Provider Relations, both working here at Phia Group. We have now added an element where we are now doing international claim negotiations for our international clients, in addition to the great clients we have here in the old US of A. So I want to thank Jason and Nick for the great additions to our team and for the amazing knowledge and experience that they're bringing to Phia and have been bringing to Phia for years. So guys, thank you for that. Last but not least, before I turn it over to Jen, want to make sure we spend a little bit of time on this. So folks, as you all know, we try new things here at Phia. And before we ever promote them or talk about them to the industry or to our clients, we always want to try it out here on our staff first. And I can tell you what we have seen so far with RightWay has been absolutely amazing. The engagement, the information, the quality metrics, etc. My own family personally has been using them. I have gone on and helped identify the right surgeon to perform a new knee replacement surgery for my father. I helped one of my neighbors identify the right surgeon for his back. I actually used it for my daughter who needed to see a specialist. And it's funny, we're at the same facility. You might have 4 or 5 different physicians or surgeons that can perform the surgery for you. You're paying the same price at that facility, yet these doctors are not the same quality within that facility. So you get information on infection rates, you get information on readmission rates, you get the number of times they've actually performed that procedure, etc. So if you're interested in working with these guys, feel free to reach out to me directly or any of our sales team, and we'll be glad to share some of the information with you. So with that, to talk about the Phia Group Consulting's most frequently asked questions, I'm going to turn it over to Jen McCormick. All right, Jen, take it on.
All right. Thank you so much. All right. We have a couple of pretty exciting FAQs that we wanted to talk with everyone about today. The first one is about a change to the preventive care requirements. So we've known for a number of years that non-grandfathered plans are required to cover preventive services at 100%. That's not new. What is new, however, is that there is continued changes and modifications to the screening requirements and the recommendations from the task force about specifically what needs to be covered under that umbrella. And it shouldn't be a shock, there is a new requirement that went into place that was added to the A list last June of 2019, when it was a different type of world, about an HIV type of screening. And as a result of that happened a year ago, the regulations tell us that a plan generally has 1 year after the date that the recommendation has gone into place or has been issued in order to make that modification to the plan. And generally, something is considered to have been issued as of the last day of the month when it was released. The last day of that month in 2019 would have been June 30th, 2019. So adding a year to that, that means that this is a mandate, a recommendation, a screening that these non-grandfathered plans should be adding and ensure that they are providing 100% coverage for as of July 1, 2020. So double check your plans, make sure that everything is set up, that you have this recommendation and screening requirement in place. Question 2. All right, this is something that isn't new, something we've been talking about in the past about the HHS rule and what it means for cost sharing. There's been a lot of back and forth. Should I, shouldn't I? Am I required? Am I not required? How is it that I'm supposed to do or deal with these patient assistance programs or these coupon programs? So finally, in May, this had been cleared up by the HHS final rule that said that a plan was not required to count the money that had been received from the assistance, whether it's a coupon, copay assistance, patient assistance by whatever name. It's not required to count towards the out-of-pocket maximum. Why is this important? So since this is something that may but is not required to be done, that means the plan has the choice. And whenever the plan has the choice to do something, it means that the language needs to be explicitly clear about how it is that it is set up within the plan language. Keep in mind, outside of the plan language piece about what the plan wants to do, that there are some other states that have been passing some different rules on this topic, putting certain things in place that may have an impact on this. So while this may not necessarily be an issue for a standard self-funded plan, it's possible that there could be a non-federal, governmental, or school district plan or a church plan, for example, that could be subject to those other regulations within the state. And with that, I'll turn it over to Brady for the political update.
All right. Thanks, Jen. Well, every month that passes by now, we're getting closer and closer to an election, and I'm very excited about it. But unfortunately, first, we have to deal with
Hey, Brady, hold
a
on.
huge failure.
First, Brady, what are you wearing? You got the Phia fleece on today? What's going on? We need to know.
It's too hot for the fleece. I have the T-shirt on today, Adam.
You're wearing an old, ratty Phia T-shirt right now?
I am.
All right, very important. Folks, we're going to make sure we send him a brand new, fresh T-shirt that's barely been used. We're going to get that to him right after the webinar. I know so many of you care about that. All right, sorry about that, Brady. Go ahead.
So what we should talk about at this point is a failure of Congress, because really that's what we've seen up and down the last couple of weeks. The two sides of the aisle unable to reach a deal on a relief package. And it's really putting a lot of pressure, not just on pocketbooks for many Americans, but on our industry too. So I want to talk about a couple of the areas that are mostly impacted. So we've heard about in the news how, for millions of Americans, their enhanced unemployment benefits have run out. You've seen eviction moratoriums expiring. But really, every day that goes by, it seems like the parties are actually less close to coming together and making a deal on this. Now they're fighting about funding for the post service. But for the health insurance industry, I've outlined about 7 areas that we were hoping would see some traction and some movement. And in fact, we did a webinar on this a couple months ago. Adam, you'll recall this. It was reasons for optimism, things we should be excited about despite having to deal with a pandemic. And all of these things are now really put in jeopardy by the fact that Congress can't come together so far to pass a bill to make many of these things a reality. So the first one, of course, surprise billing and price transparency. These two issues have been on the agenda for the Trump administration for a number of years now, and there was hope that some kind of fix would be acted on and put into a COVID relief package. What better time to deal with these issues that affect Americans financially than now? but that's not happening so far. And so we'll talk about later on what some of the states are doing to fill the void of action at the federal level. Another important issue here that's not being addressed is a telehealth policy extension. We've covered this extensively as well. Remember, this is about Congress's action to increase payments for telehealth to match it to what Medicare pays, because telehealth services have been expanded greatly during the pandemic, and we've talked about how we expect them to continue to be expanded in the coming months. And yet, that extension of the payment model is only tied to the public declaration of emergency itself, meaning once HHS declares that the public health emergency is over, then the extended or enhanced payment for telehealth also ends. And that'll be a big blow to the telehealth industry. So it would be bad for that to happen in the middle of the pandemic. It'd also be bad to see testing funds run out. So right now, we know that insurers and employers are required to cover the cost of COVID-19 tests only in certain cases. But many in the industry, and frankly, many policymakers generally, have been asking Congress to create a special fund to pay for tests that insurers aren't already legally required to pay for. That would ensure that many more people get tested. And the thinking there is that with more testing, more access to testing, we can all get over this and through this ordeal more quickly. But until there's a deal, no funding for testing at that level. Same thing for provider relief money. So remember that the CARES Act set aside almost $200 billion to offset the impact to hospitals. You had a lot of hospitals which said we couldn't survive, or we can't survive the onslaught that we're facing because of COVID-19, with elective surgeries being canceled, et cetera. And so there's an idea here that they need more money to stabilize their infrastructure, and that's not coming because of inaction in this area. The last two here, liability protections, a big deal for employers who don't want to get sued, people implementing their back to work plans, providers that have had to make decisions about care with limited supplies. They can't provide PPE, right? They're dealing with an unknown virus in many cases, and they're afraid of getting sued. And lastly, COBRA subsidies, one of the biggest things for our industry that I think could be a big problem if we don't see action on this, because we talked about how a study from HMA revealed that up to 35 million people could lose their employer insurance, and if they do, it could cause a cascade effect in the industry where you're seeing people lose their employer coverage, PEPM rates are going down across the board, risk pools are getting strained, and this COBRA subsidy idea would be a way for Congress to provide for the cost of COBRA and to ensure people can stay on their plans and help stabilize the market. So what have we seen? Despite the fact that we have no congressional action, we've seen really an attempt to provide relief via executive order. The president passed or he enacted a number of executive orders in this area on many of the benefits that expired. But the problem here is that this is really unclear whether these executive orders actually meet constitutional muster, or as one Republican senator called them, constitutional slop. And so I think the intent here is for the president to put some pressure on Congress to get them to actually do something. In the meantime, though, he's trying to legislate via executive order. And one of the things I wanted to mention in this update is he's been promising for, it feels like years now, but especially in the last couple of weeks, a new healthcare plan. And we've been watching this with a lot of interest because, as you know, the administration is currently suing to abolish the ACA at the Supreme Court. The president has promised via tweet and a number of interviews that he would have a comprehensive replacement plan for the ACA in, quote, 2 weeks. 2 weeks have passed by, and now he's saying the end of the month. So we'll have to see what that looks like. And on the next slide, Matt, we'll take a look at some of the other things that the administration has done where he's put pen to paper to make things happen. One of those areas, important for us, as always, is drug pricing. And here the president signed an executive order which is supposed to take effect next week. But the odd thing with this executive order is that he hasn't released the text of the order. In fact, when I was trying to find out what it said, one article I read said that news agencies were taking pictures of the order as he was holding it up to see if they could see what it said, and they couldn't. And the problem there is that typically the executive orders will direct agencies on what they need to do. In this case, that's not happening. But what the president has said is that this would be putting into effect a plan we've covered before, where the president wants a kind of favored nation status for drug pricing, where Medicare would pay the lowest price in the world, not the highest price in the world, and would establish this kind of international pricing index. That would be a big deal and a huge disruption if suddenly Medicare is reimbursing at the lowest amount in the world for drugs instead of the highest amount. And so the president has called on drug companies to, quote, do something before the order takes effect. So unclear if that's more noise, But it seems like here the president's theme is that he's getting frustrated with Congress not taking action, and he's stepping up and making things happen on his own because Americans are struggling out there, and so is our industry. And one last note here, you might have not noticed, or I know I'm watching this every night, is the Democratic National Convention featuring the new ticket, which consists
you're the
of.
only person watching it. There is not.
I probably am.
Watching this.
You know, it's being done virtually, and it's not very good, Adam. I'll tell you that our production quality is much better. But for what it's worth, we do have a complete ticket on the Democratic side. I want to briefly talk about what Kamala Harris's positions are on healthcare, because that's going to be important. Notwithstanding people who claim that she's actually running the show, in either case, her positions are going to impact the contender as well. And so initially, remember that Kamala Harris was a co-sponsor of the Medicare for All plan by Bernie Sanders in the Senate. But then she backed off, and she wanted to keep private insurance intact. Now, that was done because of a lot of pressure put on her. She's trying to find a middle ground. But nevertheless, she does support a public option, which would cover certain specialties like ER visits, doctor visits, vision, dental, and on and on. So essentially, she is in favor of a public option. That makes a lot of people weary in the insurance industry that that's the road to single payer. So we'll see how that impacts Vice President Biden's views, which is, as we know, is to just really bolster and support the ACA. Finally, though, importantly, she does support allowing Medicare to negotiate drug prices, which I feel like we've been saying for years with every candidate seems to support this, but it never happens. We'll have to wait and see if the president's executive order actually makes this happen. But for now, we do have a ticket put together that isn't quite as far down the road of Medicare for All as we've seen in the past, but is probably somewhere in the middle. And with that, I'll turn it back over.
All right. Thank you so much, Brady. So let's talk about my favorite thing, hot topics, what's trending in the industry, what are the things that we need to know about. Brady mentioned about the public health emergency being renewed, and that is pretty relevant for us to talk about as far as some of these topics. So importantly, when it comes to that, there are some certain provisions and things that are tied to the continued public health emergency status, one of those being the tolling on the time frames for special enrollment election, COBRA, like Brady was talking about, claims and appeals. So we still do need to make sure we're continuing to monitor those deadlines as this time frame has been continued to be renewed. Another consideration here is we're still seeing layoffs and furloughs and unfortunate circumstances where companies are going through some financial distress. You hear about on the news every day, whether it's NBC Universal was a new one that I had heard about. United Airlines is another one. And as this is happening, we need to make sure that the language that had been put into the plan or the provisions that had been put into the employment handbook or the policies that have been put into place originally months ago, that those can continue to account for the change in how things will be continuing as we're entering the fall. Kids are going back to school, and maybe this is something that hadn't necessarily been accounted for through the end of the summer. The other important consideration here, especially for schools or employers who have a university or college, is there's a lot more of this hybrid online in-person learning model. So that might be a consideration for teachers and the staff, and maybe there need to be some modifications to how it is that those employees are going to be able to continue benefits or continue on with the employer. So if you're in a situation where the employees haven't been returning to work, or maybe they aren't going to return to work for an extended period of time, now would be a great time to check in on that language and make sure that everything is aligned and there is the intent as to continue benefits or not continue benefits and offer COBRA. Just make sure that as the workforce changes are changing, that the practices and things are keeping up as well. The other note here is about the DOL FMLA forms. Those have been revised and updated, which is pretty exciting. These model notices are meant to help all of the employers when it comes to things like how the certifications are being handled and how the notification for the employees would take part when it comes to interacting with the other types of leaves. Now that we have COBRA leaves, we have COVID leaves to worry about, we have state leaves that are needing to be addressed as well. There's lots of different coordination that's going to be required, and these forms were intended to help to coordinate that and make it easier. These are optional, so this is not something that is required to be used by employers, but something I would suggest taking a look at and seeing if it could be helpful. The other unfortunate circumstance that we're seeing now is there is the winding down of some health plans. So remember that benefits are voluntary. There's no federal law that requires or mandates that employers offer benefits, although there's the ACA penalties for employers that don't. However, there are no rules that would prevent the employer from maybe reducing benefits or cutting some of the benefits. But prior to doing that, and if that is the only viable option to continue the plan, obviously it's something to consider. There are timing rules, termination rules, and it is a fact-by-fact circumstance where it comes to how that is being done. So make sure if there is the reduction of benefits or the unfortunate circumstances of a plan termination, that all of the rules are being followed, whether it is the ERISA regulations, the obligations that are outlined with the Administrative Services Agreement. All of those logistics need to be considered if that is something that is being contemplated. And last but not least, before I turn it over to Ron, about telehealth, Brady had mentioned a little bit about this too. This is something that has been an interesting issue that we have seen come up. So we know that as part of the COVID testing requirements when it comes to diagnostic testing, that is one of the ways that a plan is going to be required to cover services at 100%. However, there is the distinction and difference between telehealth services that are being offered by a vendor versus other telehealth services that maybe you're getting from the pediatrician or from your regular PCP. In that case, if that is a benefit that is being offered and available to the plan participants outside of the potential vendor telehealth services, there needs to be some language in the plan that addresses that. Otherwise, if the plan language is silent about how those non-vendor telehealth services that are not specifically related to that diagnostic 100% coverage for COVID are to be handled, it can create some ambiguity and confusion for the plan members. So make sure that is something that is addressed, because like we've all discussed before, telehealth services aren't going away. So now is a really good time to make sure everything is wrapped up and very clean and concise so the plan participants know exactly what their benefits would be. With that, I'll turn it to you, Ron.
Jen, really quick, before we go over to Ron, there was a great question that was posed, and I'm actually interested in getting this answer. Have there been any changes to the emergency sick leave or expanded that would allow leave when the employee voluntarily decides to go to online school, even though the school is actually doing in-person classes? That's obviously something I can see more and more happening, but any news on that? Any thoughts on that?
No, so there was a regulation, an FAQ a while ago that was talking about how parents were supposed to handle situations when there were capacity issues for camps. And if the child had been signed up for a camp or a program and due to capacity, they were no longer eligible to go, and that there was going to be the opportunity for a leave at that point. When it comes to school, if there is the choice, I'm not sure that you'd be able to use that parallel. I'd certainly make that argument if I was trying to make the case for it as an employee, but that's definitely a good question, something that should be hopefully addressed, as that's not going to be a problem that's going to go away.
Right, because obviously more and more people are being given choices when it comes to schooling, et cetera. And I would make the assumption that people that decide to stay at home, obviously, at least what we're seeing with the schools, teachers, stating that they're not going to return to schools to have in-person learning. I love these new words like in-person learning. I don't think 6 months ago I've ever said those words, but now it's like every day. Where because they had a health issue, right? So they decided not to go back because they have, some underlying condition, let's say. So it's a great question, though.
The other thing to consider about that too is that I don't know that it would be a total surprise that once certain schools are back doing in-person learning, that there'll be the option or a circumstance where maybe they decide that's not the best situation anymore. So this will be something that should be addressed by employers, all of us that have kids that are facing these circumstances. So something to keep in mind for the upcoming renewal.
So Ron, if you don't mind, I want to steal your thunder a little bit on this slide, because I was working on this specifically on the COVID-19 plus subrogation. So obviously many of you might have heard of this, 170-year-old person in Seattle who had, over $1 million medical bill. But, the reality, and that's obviously front page stories, but here's the reality. So what we've done is, we've added COVID because it's related directly to workers' comp potentially. as a potential subrogation issue. So since the beginning of March, and then, as you all know, we're representing close to 13 million lives. All the claims that we received since March, and whether or not they've been paid, as long as they've been processed, we get that data from our clients. So obviously, COVID now has a procedure code, right? There's a diagnosis code there. It's all tied in. Here are the numbers since March through the end of July, okay? 0.0065%. That's less than 1%, much less, are COVID related, meaning the flu they got is COVID related. The chest pain, whatever it is, the fever, that's the percentage of claims that are COVID related. We're looking at 0.058% of patients, all the patients that have had any claim, have a COVID claim attached to them. Of these, on average, it's about $7,000 so far in charges related to each one of these individual patients, and an average paid per case of $3,400. So, it's not anywhere near the typical this $1 million medical bill that we saw from Mr. Michael Floor. But to give you some context, right? In that same data set, folks, which I thought was crazy, okay? There were 6 times as many people in car accidents. 6 times. And the average charge and average paid were on average 3 times these. So again, just looking at the numbers, 6 times more claims related to COVID. 6 times more claims related to a motor vehicle accident than to COVID, and 6 times the number of patients were involved and injured in a motor vehicle accident that had a COVID-related claim. Just thought that was interesting to know. And now, Ron, I'll send it back to you.
Yeah, no, and I think that these numbers, at first they may surprise you, but when you really think about it, I think we predicted that this is what it was going to look like, because even when we look at the example of the person that we're most concerned about, right? The horror story, the worst case scenario, which is that Mr. Floor with the $1.1 million claim, take note of his age. You might recall from the story that he was a Medicare enrollee, right? And when you look at the statistics and the people who are being diagnosed with COVID, the majority of people who are diagnosed with COVID, they're diagnosed and then sent home. When we look at things like hospitalizations, inpatient stays, sort of this intensive care, there are the people who have the pre-existing conditions, which again, we're not talking about that many, but the vast majority, numbers-wise, are going to be some of your older citizens who, frankly, are more likely than not enrolled in Medicare. So when we look at these statistics, Adam, this is the data that we have from our clients who are representative of these employer benefit plans. I have to assume if we were looking at Medicare's claims data, it might look very different. But the problem is, I think we as an industry, because we just saw that there are this many people in the hospital and the claims are this high, we just assumed that that was going to be spread evenly across the population. Whereas I think that the older population is being hit a lot harder, not only as far as the severity of the disease, but hand in hand with that, the number of hospitalizations, the number of claims, and the dollar amount that's tied to it. So, I hate that anybody should have to suffer, but from our industry's perspective, I think Medicare is definitely being hit a lot harder than these private benefit plans that we represent. And that might be one reason why these numbers don't necessarily match up with the total statistics you see reported by the news. With that, we can move on to the next slide. So, understanding that there aren't going to be that many claims, because again, the majority of the claims are headed over to Medicare, and the dollar amount involved may not be as high, that doesn't mean we take our eye off the ball, right? We need to recognize the opportunities to recover money from third parties. Subrogation. Adam, you mentioned a car accident. We're doing this 6 times for every one COVID, but frankly, that doesn't mean we shouldn't be trying to recover the money for COVID. And whether it's $600,000 or $6,000, again, that's money that has to come back to the plan. So in order to enforce the plan's rights, we need to understand how subrogation is accomplished in this particular area. And COVID-19, no different than mesothelioma or a hernia, right? injuries and illness that are presumed illnesses under work comp law. That rule, which has existed, these rules have existed long before COVID-19 was even a thing on a state-by-state basis, apply here, but have applied to other diseases in the past. So we do have some sort of foundation or basis upon which we can pursue claims for COVID-19 now. And we know from having done this with other diseases historically that each state has its own rules. And the sort of the prerequisite questions you need to ask on each state-by-state basis is, one, does the state even recognize presumptive illnesses under workers' comp laws? And if the answer is yes, is COVID-19 something that's currently recognized as such a condition? You could have a state, for instance, where they recognize certain types of cancer as being a presumed hazard of the occupation, but they don't consider COVID-19 to be a presumed illness. So again, state by state, who's eligible for the presumption? Just because COVID-19 might be a presumed illness, that may be the case for some types of employees, but not others. So you have to look at how they determine who is eligible for the presumption. And then, do the specific types of workers, are they designated for COVID-19? So even though, for instance, firefighters or police officers may be eligible for presumed illnesses when it comes to things like, smoke and mesothelioma and lung disease, right? Lung cancer for a firefighter, COVID-19 may not be a presumed disease for workers' comp. So you can see how we're kind of drilling in, getting more and more detailed with every line.
Folks, one thing I want to make sure people understand is, why are they spending so much time on this several thing? Folks, here's why. Stop loss. If you have a situation where there's workers' comp, stop loss carriers are going to and should, rightfully so, be asking, did you do any coordination of benefits? Have you checked to see if any of these claims could be related to workers' compensation? This is important. You're going to have to show that you've had some kind of process, some kind of investigation done on these claims. That's why we're bringing this up, because we know this is what's going to occur. Ron?
Absolutely. So as we go to the next slide, now that we understand sort of the general rules, we have to start to analyze each individual state, because even though we're dealing with these issues at sort of a national level, and even though many of these plans are private self-funded benefit plans, the law that applies in each individual state is going to determine whether this presumptive coverage for COVID-19 or other diseases, for that matter, is included. So, Matt, can we just go to the next slide? I don't know if we're frozen here.
Really quickly, Ron, I want to make sure we respond to a question. Yeah, our algorithms test these claims as it relates to these particular states, and then obviously we would subrogate in a situation where we're allowed to subrogate.
Correct. And Adam, I know you're a big Cleveland guy, so we had to include Ohio as one of our state highlights here. It's very interesting because when you look at the types of diseases that they consider to be presumed work injuries, they're all in some way related to chemical exposure. So they're very much about environmental illness or injury. And as a result, you can imagine that something like COVID-19 may not fall into that definition. But then we look at, for instance, the question as far as, okay, if I'm in a state where COVID-19 is a presumed work illness, to whom does it apply, right? In Washington, D.C., they apply it to, quote unquote, essential employees, and they define that as healthcare facility workers, public works, food handling, social services, communications, and technology. So it's really ultimately, if I had to say in a nutshell how we do this, it's a two-part test. Number one, in the state where we're currently working, do they have a presumptive illness law, and is is COVID-19 one of those presumptive illnesses? And then part two, to whom do these presumptive illnesses apply? And again, to Adam's point, it's really important to just cross your T's and dot your I's, more to prove that you did the investigation and that it doesn't necessarily, the third party liability either does or doesn't exist for a purpose of satisfying workers' compensation. But then again, looking at the claims that we've been seeing and the numbers we've been seeing, I think it's more likely to be deaths by 1,000 cuts instead of one massive claim. So keep that all in mind. Again, as this disease continues to sort of change and the groups that are being impacted by it change, this may become a bigger issue. But for now, it's better to be prepared and not need it than need it and not have it. And speaking of people that, it's better to have them but not need them is Brady Bizzaro. Brady.
What a great transition there, Ron. Appreciate it. Well, look, I want to keep on the theme of bashing Congress because that's kind of what I've been doing today. And here's another area where we can do that, and that's about surprise billing and the lack of action we've seen in this issue. You think that a global pandemic would finally get Congress to act here, people already hurting financially, and with the pandemic only increasing the number of out-of-network bills we've seen by providers. Unfortunately, that hasn't happened. Negotiations have stalled, and at the federal level, nothing's happened. But before we talk about what some of the states are doing, I wanted to mention a publicly available report that you can all find here that was released by HHS, which goes over the need for protections against surprise medical bills. Back in June 2019, the president signed an executive order which directed HHS to come up with this report. And it's actually a really good report. It goes through state by state about what's going on in those states, what they're doing to combat the problem. It explains what the problem is. For people who may not remember or may not have a good grasp on why this is a problem, I really recommend you read that. It also talks about the role of private equity companies in increasing the prevalence of surprise bills, which makes the problem a lot worse. So definitely look at that report if you can. But we're here to talk about what some of the states are doing, because while we've seen a vacuum at the federal level, some states have stepped up. And we currently have about 16 states that have actually passed some kind of bill on surprise billing. But you can see here from this list that we're actually watching pretty much all of the states. We have about half of them listed here. But it's important to remember that when we talk about what states are doing to combat the problem of surprise billing, these laws don't apply to self-funded plans. Remember that self-funded plans enjoy ERISA preemption. Still, there are ways that states can regulate self-funded plans. So one example would be the state of New Jersey, which has a law where it allows self-funded plans to opt in to the state's balance billing dispute process. And of course, states can regulate providers and doctors and hospitals directly on that end. But it's still clear that a national standard is better. It's needed here because of the ERISA problem. And most states that have acted in this area are using either one or two different methods or a hybrid of the two. And those methods are really a standard, a payment standard for out-of-network providers, or an independent dispute resolution process, a sort of baseball negotiation style. And in particular, I want to talk about 3 states briefly here in 2020 that have acted here: Georgia, Maine, and Virginia. They have each adopted a comprehensive protection against balance billing. They've taken a hybrid approach with some version of a payment standard saying you must accept X amount of dollars for an out-of-network provider, but also provides an opportunity for independent dispute resolution. But it limits that opportunity because what they don't want to happen is providers to engage that process on every single balance bill, because clearly those providers have a lot more resources than the average person or the average plan in many cases. And so there are some very smart limits that have been placed on how often providers can initiate this dispute resolution mechanism. And Georgia in particular, according to this report from HHS, could serve as a model for a federal bill. So we'll wait and see how that plays out. But I mentioned that you've got 16 states that actually have passed a bill on this issue. In the next slide, you can see a few more examples of the states that have acted here. So California, Texas, Florida, New Jersey, and New York are really, in Pennsylvania, are considered some of the stronger states in this area because they have these hold harmless provisions in their state laws, which basically say that if you are enrolled, or rather, if you are facing a surprise bill in an out-of-network emergency situation, you can't be balance billed. Or if you see someone who's in network. But if you are on a PPO plan and you visit someone who's out of network, even accidentally, that is not necessarily covered. So that's where you've got to be careful. But these hold harmless provisions are really the first step in protecting patients. Like I mentioned, in New Jersey, there's this sort of special idea here of allowing self-funded plans to opt in to the process in case there's an issue there with the ERISA preemption. I want to mention one last thing before I turn it back over here, and it's what is our industry doing about this more globally? And one example would be what SIA is doing in the state of Colorado. Just a brief reference to a case here where a woman had surgery. She was told she would owe $1,336, but received a bill later on for $300,000. And the hospital there argued that they had read her benefits card incorrectly. So before her surgery, of course, she signed an agreement saying she would pay, quote, all charges of the hospital. And you can imagine after they discovered the mix-up there, the hospital sent her the bill. And the hospital sued her because the vendor in this case paid the hospital what they considered to be a reasonable amount, in this case, $74,000. So the hospital sues the woman in Colorado. The trial court actually found in her favor and said she only owed an additional $700. But the provider appealed, and the Colorado Court of Appeals reversed the decision and so far has ordered her to pay the remainder of a $300,000 bill. In this case, Phia has filed an amicus brief in support of this woman, arguing that the Colorado Supreme Court should take the position of a trial court, and just highlighting how ridiculous this bill seems in light of the fact that this woman didn't do anything wrong. The hospital misread her card. And this is an example of where these issues are really a problem for states, especially now in the pandemic. And that's why Colorado looks like it's poised to pass a very strong law against balance billing. And we'll be watching to see what that looks like. But at the end of the day, once again, what we need here is federal action, because one law at the federal level would apply to all plans across the board. And I think it could be devised carefully based on this report using a hybrid method, both of a payment requirement and an independent dispute resolution process that I think could be one of the better solutions to this problem. And with that, I'll turn it back over.
Before we go over to
Jen.
Jen, I want to just bring up, I want to talk about a couple comments that were made from the chat. So a couple people have said, how do you know if someone really contracted COVID at workplace? I don't know, but it doesn't matter. It's not our job. Our job is, if we find that someone did file a workers' comp claim and that claim was accepted as it relates to COVID, then we had to be reimbursed, right? So here's what we do know. Of all the claims that we had submitted that we felt had a potential viable workers' comp claim, we know that 21% of all the cases that we investigated for potential workers' comp as it relates to COVID were accepted by the workers' comp carrier thus far, 21%, which is a pretty high amount. In addition, there were some questions that we received from people saying that the facilities that they had COVID treatment claims at were not applying normal network discounts on their claims, even though they were network claims. That should not be happening. They should be allowing the same discount. The type of procedure, the type of code shouldn't make a difference. If you want, you could have your network contracts reviewed. That's what I'd be checking. But typically, if a treatment is at a facility and that facility is in network, all treatments within that facility, unless they buy an out-of-network provider, right? We've seen that too as it relates to the surprise balance billing within that facility. Otherwise, it should be treated as a typical in-network claim. Jen?
Hey, Adam. One thing real quick I just want to cover as well. You mentioned the question about proving whether somebody contracted COVID-19 at work. With few exceptions, the presumptive laws that we were talking about, the reason they're called presumption laws is because if you contract COVID-19 and you are diagnosed with COVID-19 and you are an essential worker as defined by that law, it's actually presumed that you received that you contracted that disease at work. So it's less about proving that you got it at work and more that the carrier has an opportunity to deny the claim, and then it's on them to disprove it. So that's why you still see some denials, but that's the difference.
Is Brady essential here, Ron?
You know what? Honestly, I think it depends on the definition of essential. And in Massachusetts, I'm pretty sure it's just if you show up, you're essential.
Okay.
Only every 4 years.
Turn it over to Jen.
All right, I'll get through this piece quickly. So there are a couple of considerations here. Balance billing is something definitely to be concerned about, especially as it relates to COVID-19. There's a lot more circumstances now where people are looking to go to an out-of-network facility because maybe the hospital that they otherwise would have gone to is at capacity, or maybe they're being sent elsewhere. So when it comes to the COVID-specific or the presumptive COVID-specific type of claims, as a result of some of the regulations that have been put into place, and Brady had mentioned earlier the provider relief funds, for those physicians or hospitals or providers that are accepting those, when it comes to the COVID-19 type of care, there should be a bar. The intent is to be a bar from balance billing in those circumstances. So just keep that in mind specific to the COVID piece of this. In general, there are other circumstances when balance billing shouldn't be happening. That would be when there's a network circumstance, or when there are provisions within the plan document or an agreement that say that if you go to an in-network facility but you receive services from an out-of-network professional within that facility. And also know that there are some sort of standards that have been put into place. The one that we've talked about in the past is the emergency services rule, or the GOT rule, the greatest of three rule, when it comes to the circumstances for what the plan parameters should be when it comes to how those are being paid, whether it's the in-network rate, the Medicare rate, or whatever the UCR methodology is that has been set into the plan. But keep in mind, unfortunately, that there's circumstances where these protections would not apply And as Brady had also mentioned, one of those is being part of a self-funded plan. But have no fear. I'm going to turn it over to Jason, and he's going to make sure that everyone understands the types of responses that we can expect from the providers. Jason?
Jason, it's your first time.
Yeah, so
be careful, my friend. Everyone's listening.
I'll try not to mess it up.
All right, buddy.
All right. So in terms of talking about provider types, that's already a bit of a weird thing. You have to remember, you really have the original rendering provider or servicing provider, and then you have all the other people that do revenue cycle management or collections. So as I go through the types, just remember, I could be emphasizing one that is more the actual rendering provider and one is more a downstream billing provider, if you will. So a desperate provider willing to make a deal, this is what we're seeing more on the hospital side these days. So we're dealing with the actual hospital, not a third party. And what they've actually told us is that, they're selling their bad debt for pennies on the dollar. And so a cooperative agreement with a plan with someone that's reasonable, that can explain what's going on, there's definitely opportunities there for that type of reasonable discussion. But I'd like to think that was always there. I think COVID probably made it a bit more candid in terms of what providers are talking about. So again, you just want to know your metrics, you want to know your plan allowables, but don't bid against yourself in the sense of thinking that every provider is going to be, predatory in their receivables practice. A lot of them are open, and I think if you're candid and honest, I know that sounds idealistic, but that can go a long way. Next slide, please. So the hungry provider, this is where I'm seeing a bit of a bloodbath. I would actually call this more the billing provider. So don't think of the rendering or servicing provider. Think of the downstream agent, third party, receivable management. This is where the private equity is coming in and consolidating. So you remember a few years back, all the PPOs started buying each other out, and there was massive PPO consolidation. I would say that we're at that COVID rapidly caused consolidation at the billing agent level. So you'd see some of the largest collectors in the market buying other of the largest collectors in the market, so on and so forth. But this is where, if you're a smaller player, say a mom and pop coder biller, maybe working out of your garage, this is where we see a lot of frantic activity, a lot of all or nothing, chest pounding, things that are really quite dramatic, but frankly, don't add up to anything for us. We track all the relationships between rendering and billing providers. So it's just better to stand your ground. Someone's being aggressive, stand your ground. Don't even look to try to reason with them. What's the old saying? It's difficult to get a person to understand something when their salary depends on them not understanding. So just give up on the whole mutual meeting of minds. Eventually, they will come to a point where they are either reasonable, or if they're part of a payment stack, it'll just go to the next billing agent who's probably even more interested in being reasonable, possibly for a settlement. Next slide, please. The righteous provider, I would use the term also traditional provider. This is the provider that has lived in 45 years of managed care history, where they control their contracts and then they control their out of network, very black and white, very binary. And so their position on their negotiation is that they are not going to negotiate with health plans. They are going to, if they negotiate with a health plan, it's through the structure of their managed care department. And if anyone's ever tried to do direct contracting, first question is, how many lives do you have? And then you get bracketed into discounts. So for them, as long as they see insurance, they're not going to negotiate. They're going to say, pay up to my full bill charges. Next slide, please. On the good side, however, is that given the way that they look at things, they say, okay, I structure my networks, I structure my contracts, and how I deal without a network. But if it's truly the member, then we see, and also these large organizations having a compassionate financial assistance program where they will offer reduced rates. So if you are working, say, in a balanced billing context or a client or a member-facing context, you can work with them. And then if you have the structures in place, you can fund the money through the member to achieve that settlement. But the whole idea of trying to get to a traditional provider to just cut through that paper, cut through that waste of time can be difficult at times. But if you have the right partners, you can get through that through the member-facing side. And lastly, slide. The oblivious provider. This is really what I would say is once you're getting into the payment stack of a post-rendering provider, third-party agent, collector, they have a service level agreement where they literally they're like parrots, I want a cracker. That's basically what they say. Can I talk to someone? No, 10%, 20%. And so they're really quite oblivious. What you'll want to do here is either try to escalate within the organization to someone that's just not a frontline employee on page 7 of the training manual. You'll want someone who actually has authority to review what they're doing. Phia, it's handy because of a lot of our communications come from attorneys that has an implicit escalation mode. So we can kind of mow through that administrative morass a little bit faster, but it's still out there. Sometimes we're able to, because we track all the billing providers off the rendering, we can tell them, hey, we know you only have the claim for another 30 days, at which point it goes to this next billing provider. If you can get us consideration, we'll move this thing along. Sometimes you can go back to the rendering provider saying, hey, I know how this goes. It's 60-day loops in your funnel. This is going to age out and it'll come back to you anyway. And we settled one just last month. Can we accelerate that process? Can you call this claim back? Sometimes they can, sometimes they can't, based on their own contracts with their vendors. But these are just things to keep in mind when you're dealing with different providers. The most important takeaway for today, remember that providers are not just one entity. They're a multitude of entities tied together through service level agreements, and you really have to know them all to apply a custom strategy that will actually have a chance of working out for you to your benefit, the benefit of your clients. That's it.
Jay, you can always add to that and just say the biggest takeaway from today is to actually just send me your cases so that you can negotiate them. You always do that too.
Yeah, but I don't want to be too salesy. But yes, that's a good idea too.
It's a great idea. It's all you still on. Jay, honestly, great job. Let's go to the next slide, buddy. So obviously, folks, we're going to get back to all the great questions and stuff. Please, folks, jump on LinkedIn. Make sure you jump on LinkedIn and follow us there. The more and more numbers of people that we have following us, the better we can protect Matt Payton's job. As you know, hashtag Save Matt's Job. Join us for our next free webinar, September 22nd, 9/22/2020, 1 o'clock Eastern Time. I'm not sure what we're going to talk about, but you know it's going to be fun. On behalf of Ron, Brady, Jen McCormick, Jason, and myself, and also Matt, our producer, thank you so much for joining us. We're very humbled by the fact that so many of you dial in. Have a great day, and thank you.